Hello everyone. So today we'll see about diuretics again. This is the part 2. So we'll see all the drugs and ADRs as well as the pharmacokinetics, and I'll explain the sodium and water retention in chronic heart failure, and this one, what do you say, consequence of the diuretic treatment. So let's start with the first weak diuretics, that is carbonic anhydrase inhibitors. If you remember in the asterisk class, I explained that this is the inhibitor of bicarbonate reabsorptions. Okay, so the drugs includes acetazolamide, dichlorphenamide, and methazolamide. So do anyone remember where did I say the site of action for carbon? Yeah, proximal tubule as well as early. Yeah, fine. So the first one is acetazolamide. So the indication includes acute mountain sickness, and that is high altitude as well as cerebral edema. For this indication, the dose is 250 mg BD, that is in the oral dose. Okay. The second one is elevated intraocular pressure associated with acute angle closure glaucoma. Okay. For this one, the dose is 500 mg OD oral as well as IV. For the third one, idiopathic intracranial hypertension, the dose is 250 to 500 mg BD. And for the metabolic acidosis, the dose is 500 mg OD in the IV form. Okay. Yeah, alkalosis, metabolic alkalosis, 500 mg OD in the IV form. So coming to the pharmacokinetics, we'll see the onset of action for tablet is 1 to 1.5 hours, and for IV it is 2 to 10 minutes. Okay. And the absorption is rapidly absorbed, and the distribution is through erythrocytes, kidneys, and blood-brain barrier. Okay, the protein binding is 95%, and T half is 2.4 to 5.8 hours, and metabolism is it is not metabolized. Okay, and excretion is through urine 70 to 100%. So coming to the ADR for carbonic anhydrase inhibitors is flushing, skin photosensitivity, hyponatremia. I explained this yesterday also, the mechanism for all this. Hyponatremia, hypoglycemia, hypokalemia, and there is a decreased appetite levels. Okay. So first class is done. This is the weak diuretics, and for methazolamide, the indication is glaucoma, oral 50 to 100 mg 2 to 3 times daily, and T half life is approximately 14 hours. Okay, understood? Okay, now the second one is osmotic diuretic. It is the inhibitors of water and sodium reabsorption. Okay, so which is the site for osmotic diuretic, site of action? It is descending loop of Henle. Okay. So the first drug is mannitol, isosorbide, and glycerol. I'll just explain about mannitol since it's there in the formulary. And indication is elevated intracranial pressure. Okay, in the elevated intracranial pressure, we'll use 1.25 gram per kg IV infused over 30 to 60 minutes. Okay, and in the elevated intraocular pressure, we'll use 1.5 to 2 gram per kg IV infused over 30 to 60 minutes again. Okay. So pharmacokinetics is onset of action is seen in 1 to 3 hours after IV administration, and duration of action for intraocular pressure reduction is 4 to 6 hours, and for intracranial pressure reduction is 3 to 8 hours. Okay, this is the duration of action. And metabolism is through liver, and glycogen is the metabolite. The action is not known yet. So T half life is 100 minutes, approximately 2 hours. And excretion is through urine 80%. The ADR includes electrolyte loss, thirst, and because of the thirst, like dryness of mouth is seen. Okay. So the third one is loop diuretics. It is the inhibitors of sodium, potassium, and chloride co-transporter. Okay. So where do the loop diuretics act?
Ascending loop.
Yeah, thick ascending limb of loop of Henle. Okay. So the first drug is furosemide, torsemide, and bumetanide. So furosemide is mostly used in our hospital, but torsemide has the most efficacious like bioavailability. According to the bioavailability, torsemide is the most efficacious. So coming to the furosemide, indication is ascites due to cirrhosis, 40 mg OD. Do you remember this, what I explained yesterday? So ascites due to cirrhosis. In ascites due to cirrhosis, the first we can combine with the spironolactone potassium sparing diuretics 100 mg till loading dose up to like maximum 400 mg, okay, in the ascitic condition, and 40 mg is added, furosemide is added, and the maximum dose for the ascitic condition is 160 mg once daily, okay. So the second one is edema, IV oral 20 to 40 mg OD will use. So coming to pharmacokinetics, onset of action in oral and sublingual is 30 to 60 minutes. For intramuscular, it's 30 minutes, and for IV infusion is 5 minutes. Okay. So coming to bioavailability, bioavailability and all the pharmacokinetic parameters for loop diuretics is very essential. Should remember this. So bioavailability is 47 to 64%. Okay, in the oral form, and duration of action is 2 hours for IV and 6 to 8 hours for oral. Okay, so metabolism is through liver. It is metabolized through liver, furosemide, and approximately 10%. As well as glucuronide is the metabolite. The action is still unknown. Okay, so T half life is 0.5 to 2 hours. 0.5 to 2 hours in non-renal failure conditions. Okay, yeah, and 9 hours in ESRD, in stage renal disease. Okay, so this is in the normal condition, when for the normal human beings who doesn't have the renal function disorders and all, 0.5 to 2 hours, and for renal condition in stage renal disease especially, it is 9 hours is the T half life. Okay, so urine it is excreted through urine 50 to 80%. Fine. Okay, now the ADR for loop diuretics is AKI, that is when acute kidney injury is seen when there is a fluid loss, that is dose related. Okay, and hypovolemia, all the electrolytes imbalance is seen. Hypovolemia, hypocalcemia, I explained yesterday. Hypocalcemia, hypokalemia, and hypomagnesemia is seen, and because of this reason, cardiac arrhythmia is mostly seen because of the even loop diuretics. Okay, and autotoxicity is there, and hyperuricemia is there, gout is present. Okay, the ADR. So coming to torsemide now, the second drug of loop diuretics, and the first indication is edema, 10 to 20 mg per oral every day. Okay, and cirrhosis, liver cirrhosis, 5 to 10 mg per oral every day, and in hypertension we use 2.5 to 5 mg per day, every day, so in the oral form. And even the liver cirrhosis, the dose is according to the similar to the furosemide, the ascitic thing. Okay, it's almost similar, both of it, and even the ADR is same as the torsemide. Torsemide ADR is same of the furosemide. Yeah, now fourth one is thiazide diuretics. It is the inhibitors of sodium and chloride co-transport. Yesterday I explained the thiazide, where does it act? Yeah, early DCT. Yeah, fine. So hydrochlorothiazide, chlorothiazide, these are the benzodiazines, and chlorthalidone, metolazone, indapamide, this is the thiazide-like diuretics. Okay, so let's study about the hydrochlorothiazide. The first indication is calcium nephrolithiasis. This is the kidney stones. Okay, during this time the oral dose is 25 mg OD. It may reach to, we can for the further complications we can use 50 to 100 mg per day. Okay, and in diabetic insipidus, that is nephrogenic conditions, we use 25 mg OD or BD. Okay, and in edema we use 25 to 50 mg OD or BD, and for hypertension conditions we use 12.5 to 25 mg OD. Fine. So now coming to pharmacokinetics, the onset of action is approximately 2 hours, and duration is 6 to 12 hours. It is well absorbed, that is bioavailability is 65 to 75%. It is distributed well, and protein binding is approximately 40 to 68%. Okay, and it is not metabolized as similar to the carbonic anhydrase inhibitors. So the T half life is 6 to 15 hours, and it is excreted through urine. Okay, and ADR is the same thing, electrolyte imbalance, hypokalemia, hypocalcemia, hypomagnesemia, and hyponatremia is seen. Okay, and hyperuricemia is seen even in the thiazide diuretics. Right. Now coming to the loop diuretics, it is the inhibitor of sodium reabsorption and potassium secretion. Okay, potassium sparing diuretics. It is the inhibitor of sodium reabsorption and potassium secretion. Okay, where does this act? Potassium sparing diuretics, late DCT and collecting duct. Okay, so the first drug is spironolactone, eplerenone, amiloride, and trimterene. So indication for spironolactone includes ascites due to cirrhosis, 100 mg. It is the first line treatment I explained yesterday. OD. And for heart failure, actually it is not properly preferred, but if it is actually required, then we use less. It should be less than 25 mg. Okay, and for heart failure with preserved ejection fraction, the dose is 12.5 mg OD, oral dose, and heart failure with reduced ejection fraction, the dose is 12.5 to 25 mg OD. Okay, oral dose. And for in hypertension cases, as I said, like in normally they don't use, but if it's actually required, then 25 mg is preferred, OD, oral. So coming to pharmacokinetics, the duration of action is 2 to 3 days, that is in the tablet form, and for tablet form 2 to 3 days, okay, oral form. And absorption is, the bioavailability is approximately 90%. Metabolism is through hepatic, it is rapid, and T half life is 1.4 hours in the oral form, and excretion is through urine and bile, that is like primarily through urine and secondary through the bile. Okay, and ADR is gynecomastia, dose and time dependent, hyperkalemia, dose related. Gynecomastia I explained yesterday, it is because of the decreased testosterone in the male member. Okay, so now coming to the sodium and water retention. This is the overview of the sodium and water retention in the chronic heart failure. So when a person comes with chronic heart failure, there is decreased baroreceptor sensitivity. Okay, so decreased baroreceptor sensitivity index is there, that will measure to see how much is the control of the baroreflex to the has on the heart rate. Okay, did you understand? Should I explain again? Okay. This is like, I'll explain this is the overview of the sodium and water retention reabsorption in the chronic heart failure. Okay, so in chronic heart failure condition, there is decreased baroreceptor sensitivity. There is like neurological disorders and all the comorbidities. When if the patient has, then there will be decreased baroreceptor sensitivity. There is a baroreceptor sensitivity index, okay, that will measure to see how much control the baroreflex has on the heart rate. Okay, fine. That will increase the sympathetic and renin, angiotensin, aldosterone activity. Okay, and that will lead to decreased post-glomerular capillary pressure plus increased peritubular oncotic pressure. Okay. See, when there is increase in the sympathetic and RAS activity, it will increase the decrease the post-glomerular capillary pressure, and it will increase the peritubular oncotic pressure, which will the sympathetic and RAS activity, increased sympathetic and RAS activity, as well as this condition will lead to increased proximal tubule sodium and water reabsorption. Understood? So because of this reason, there is a decreased distal sodium and water delivery. Okay, because of all this condition. And when there is a decrease in the distal sodium and water delivery, it will lead to resistance to natriuretic peptides. Okay, so as well as the failure to escape from aldosterone is seen. So because of this reason, there is a sodium and water retention reabsorption in the body, and because of this reason, there is an increased cardiac filling pressure, which will lead to chronic heart failure. Okay, should I explain again or something? It's fine. Okay. So now coming to loop diuretics. Loop diuretics, 90% of the patient, in 90% of the patient who has decompensated heart failure, loop diuretics is used. Okay, and in heart failure with preserved ejection fraction, larger dose is not recommended. Okay, of loop diuretics, and large single daily dose of loop diuretics may not decrease the congestion in the heart failure, but while similar doses given in 2 to 3 times may be effective. Okay, I'll say it again. See, large single daily dose, okay, of loop diuretics may not decrease the congestion of the heart failure, but while similar doses given 2 to 3 times, smaller doses given 2 to 3 times may be effective. Okay, and in heart failure patient, continuous infusion is required. The furosemide continuous infusion is required. And in thiazide diuretics, the condition in the heart failure is it will decrease the blood pressure, which will decrease the plasma volume, and it has the vasodilation effect. I explained this yesterday, vasodilation effect. Yeah. So now coming to the consequence of the diuretic treatment, now like overview after part 1 and part 2, the consequence whatever is seen in the diuretic treatment is when there is a over diuresis, there is a decreased cardiac output which will decrease the kidney function. Okay, because of all the over diuresis thing, it will decrease the cardiac output which will lead to decreased kidney function as well. And when there is a loop diuretics which blocks the sodium chlorine uptake, which will stimulate the RAS, renin angiotensin aldosterone system, which could worsen the cardiac remodeling by angiotensin and aldosterone. Okay, did you get it? Yeah, so loop diuretics blocks the sodium chlorine uptake, which will stimulate the RAS system and which could worsen the cardiac remodeling by angiotensin and aldosterone. Okay, and all diuretics except for potassium sparing diuretics leads to hyperuricemia. Only this has got the leads to, I mean like all diuretics except for potassium sparing, all the diuretics has the side effect hyperuricemia, gout. Okay, and hypokalemia, hypomagnesemia and metabolic acid, all these metabolic acidosis may lead to cardiac arrhythmia. So the dose calculation and all should be monitored properly. Okay, so to be continued, antidiuretics I will explain in the next class.